too. Good morning, good afternoon, good evening, wherever you are. A warm welcome to you from Duke Global Health Institute. My name is Kearsley Stewart, and I'll be doing brief introductions. And welcome to webinar number 2 in our 5-part series on COVID vaccine preparedness. I'm pleased to introduce the moderator of today's webinar, Dr. Mike Merson. Dr. Merson is the Wolfgang Jocklick Professor of Global Health and Professor of Medicine at Duke University. And he was the founding director of the Duke Global Health Institute, served as Vice President and Vice Provost for Global Affairs at Duke University, and as Vice Chancellor for Duke National University of Singapore Affairs, and the founding director of SingHealth Duke and US Global Health Institute. Prior to joining us here at Duke, he was the first dean of the Yale School of Public Health, and he also directed the Center for Interdisciplinary Research on AIDS. Previously, he directed the WHO Diarrheal Diseases Control Program and the Global Program on AIDS. Mike has served in advisory capacities for many institutions and organizations, including UNAIDS, WHO, the Global Fund, World Bank, the World Economic Forum, the Bill and Melinda Gates Foundation, and on several National Institutes of Health review panels and advisory committees. And with that introduction, I hand over the mic to our moderator, Dr. Merson.
Thank you, Karrie. Thank you for your kind introduction. It's my pleasure to welcome everyone. Our topic today, is, you all know, is COVID-19 vaccine hesitancy, which WHO defines as people's decision to delay or refuse vaccinations, despite the availability of vaccines. Vaccine hesitancy has existed as long as vaccines have existed, but this issue has been greatly magnified during the COVID pandemic, driven largely by misinformation and concerns about the safety of the new COVID vaccines. The current landscape of these vaccines is, yes, it is complex. There are, by last count, at least 9 different vaccine candidates with varying efficacies being used around the world today, with many more in development. But at the same time, meanwhile, the emergence of COVID-19 variants has raised questions about continued vaccine efficacy, and we have seen new waves of infections in some parts of the world. To discuss this complex landscape and its impact on vaccine hesitancy, I'm pleased to welcome 4 panelists. They have a breadth of research and experience ranging from vaccine development to individual decision-making, provider challenges, and system-level contributors to vaccine hesitancy. I'll just very briefly introduce them now. First, we have close colleague Tom Denny, who is the Chief Operating Officer of the Duke Human Vaccine Institute, Professor of Medicine at the Duke University Medical Center, and an affiliate member of the Global Health Institute. Tom is a member of the COVID Medical Testing Subcommittee of Duke University School of Medicine, has been very involved in the testing that's been going on the campus, and he is a senior investigator in the NIAID Vaccine and Treatment Evaluation Unit. Welcome, Tom.
Thanks, Mike.
Next, we have Jen Siler from the Sabin Vaccine Institute. She's the Vice President of Global Community Engagement and leads Boost, a global community where immunization professionals connect, learn, and lead. Before being at Sabin, Jen served as the Innovation Team Lead and Senior Partnership Advisor in the Global Health Bureau of USAID. Jen is a graduate of Duke, the Fuqua School of Business, and has connections also with the Duke Global Health Institute via her work with innovations in healthcare. Jen, glad to have you. Welcome back to Duke. Third, we have Lavanya Vasudevan. Lavanya is an assistant professor in the Department of Family Medicine and Community Health and the Global Health Institute at Duke. She is also a member of the Duke Human Vaccine Institute, and a faculty affiliate with the Center for Health Policy and Inequalities Research and the Center for Policy Impact in Global Health. Her research focuses on studying the timeliness of vaccinations, identifying vaccination barriers, and understanding the role of misinformation in driving vaccine hesitancy, a real expert in the field of vaccine hesitancy. Welcome, Lavanya. And our last, but certainly not least speaker, particularly pleased to welcome Mohammed Pate. He's the Global Director of Health, Nutrition, and Population, and the Global Practice of the World Bank. He's also Director of the Global Financing Facility for Women, Children, and Adolescents housed at the bank. Dr. Pate was, until recently, the Chief Executive Officer of Big Win Philanthropy based in the United Kingdom, and prior to that, held several senior positions, including the Minister of State for Health in the Federal Republic of Nigeria. Also, before that, joined our faculty and taught courses for us in healthcare management in the master's program. Welcome back to Duke, Mohammed. So I will now ask each panelist an opening question. And then we'll move to Q&A from the audience. So please, I'd ask the audience to think about what you might want to ask these panelists and type any questions that you have in the Q&A window. And we will put them together and address them to the panelists. So in that way, let's get started. I'll start with you, Tom. There have been new reports from the Kaiser Family Foundation survey in the United States and the global survey by Imperial College of London, which suggests that the COVID-19 vaccine acceptance is thankfully slowly increasing. However, South Africa recently stopped its rollout of the AstraZeneca vaccine after reports that it was ineffective against the dominant COVID-19 variant in that country. And questions have been raised about the safety and efficacy of other vaccines, not well known in the States, but known around the world, that are made in China, Russia, and India, and are major sources of COVID vaccine. In light of the new variants and concerns about vaccine development, how can we ensure that the increase in vaccine acceptance that we've started to see is sustained?
Thanks, Mike, for having me as a participant today, and for the Global Health Institute for putting this panel together. Great questions. So first, I think it's important that we start off and say we have a lot to celebrate. Never before in history have we come in such a short period of time as identifying a new pathogen and then coming forward with so many vaccine candidates in such a short period of time. Having said that, there are always questions, as you alluded to early on in your introductory remarks, about vaccine hesitancy. As you know, we're taking a vaccine product and we're giving it to people that are healthy, as opposed to people that are sick and taking a pharmaceutical for some sort of illness that you're trying to correct. So there's always a little bit more focus and attention, I think, around giving something to people that are healthy, and especially as you move down the line towards doing this in younger children, it just brings up that question more. I think one of the ways of approaching the challenges that we have is that we need to have good clinical trials that take us through the typical phase 1, phase 2, and phase 3 efficacies, and then we need to be transparent with the data. We need to put it out there in a manner that everyone can understand. And we also have to understand the limitations of different regulatory environments of different countries. Not every country runs their clinical trials at the same way that the US does or the EU, the European Union does. But it's important that we understand where those differences are and try to be as transparent as possible. And then what I would, I'm not surprised that, we're seeing issues of variants and the challenges there, But again, we can stay ahead of this, and if we develop the appropriate clinical trials to show that a vaccine does provide coverage to a variant, and we're transparent with that, I think we can help overcome the hesitancy or the concerns that people have. And the last thing I guess I would point to is that, again, you know, if we look at where we're at today, I think today we'll probably cross the about 65 million people in the U.S. that have been vaccinated with one of the two EUA-approved vaccines. And I think if there was significant adverse events that were out there, we would be hearing about it by now in that many people having admitted. You can say that, well, maybe in a rushed phase 1, 2, and 3 trial like we did, we tried to fast track things. Maybe you didn't see all those adverse events, but certainly by having vaccinated 65 million people in the last 2 months, I think you would have seen if there was some significant adverse events that could develop, you'd start to see it by now, and we haven't seen it. You know, you may see some allergic reactions to a small number of people that are having some allergic type reactions early on. That's usually within minutes of having the vaccine administered. And the other part I would point to the issue of the safety is most of the adverse events that occur in people upon the receiving a vaccine occur within days to weeks, not months or years. So again, I think we're building a track record here. It's incremental, but we're building a track record to show that at least the vaccines that are EUA approved today, that are being used in European countries or the US, I think are safe. As far as the vaccines being manufactured in China and India, I think we have to get more experience. We have to understand how the trials were done and understand what data was collected as part of those trials and make sure that they're equivalent.
Okay, Tom, very good. And those numbers of vaccinated you're referring to, of course, is just in the US.
That's correct.
The total number getting the vaccine in the world is obviously much greater. Okay, thank you. Jen, let me ask you, with the rapidly changing landscape of information, it really is rapid. Every day we get different news, more news. Government health agencies and health professionals need to be prepared to answer the public's questions about these vaccines to inspire confidence. I mentioned already that you lead the BOOST community, also the COVID-19 Vaccine Equity Project that support immunization professionals in low and middle income countries to prepare for and operationalize equitable COVID-19 vaccine programs. It's a great challenge, but we're wondering if you could tell us what have you learned about the challenges that immunization staff are dealing with on the ground, and how is your organization supporting immunization professionals to manage these challenges?
Great. Yeah, thank you, Mike, and good to be back on campus, even if it is remotely. So as Mike just mentioned, the BOOST community is a platform focused on supporting immunization professionals worldwide, in particular in low and middle income countries. And today we have, I just looked it up, over 1,300 members and from 127 countries. Before our launch, which actually just happened about a year ago, we spent a few months interviewing immunization professionals at every level in the system. So from national all the way down to facility throughout East Africa. And we were looking to understand what the needs and gaps were in their everyday work. And what we heard then, and actually know has just been exacerbated now, is that one, that subnational staff do not have channels to communicate with one another and kind of problem solve together. Staff are working really long hours and getting burned out quickly, which is really leading to high turnover. And lastly, national immunization staff program decisions continue to be political. And so staff do not feel empowered to really drive change. These core challenges have only been, of course, exacerbated by COVID. And with that, the challenge of vaccine hesitancy has become even more complicated. So with an appreciation of the gaps that we defined in the system, we shaped the BOOST platform with a real focus on enabling those connections between immunization professionals and providing opportunities for foundational learning on leadership and advocacy through events and workshops and courses. And so we launched Boost in January of last year, and just a short time later, of course, COVID hit all of our shores. We appreciated right away that we needed to understand kind of what are the new challenges and issues immunization professionals were grappling with at a global and national and local level. So we worked with WHO and UNICEF to push out global pulse surveys in April and May of last year. And from these surveys, we received thousands of responses from over 100 countries. And we learned that folks were most concerned about vaccine demand and hesitancy. And of course, when you look at that, there's just so many layers to it. That included kind of more hesitancy around routine vaccines, but also hesitancy about the upcoming COVID-19 vaccines, trials, all the things that were happening in the news late last spring, early summer. And of course, other pieces that people highlighted were infection prevention control and returning to routine immunization, more questions about kind of the vaccine itself and when that was coming out. And of course, the concerns have just lingered and become, around hesitancy, become one of the most talked about topics on Boost and within our courses. So once we kind of received this information, we wanted to react and build content that folks could engage with. And so we worked with UNICEF and WHO and CDC, and in particular worked with UNICEF on a series around vaccine hesitancy, which a lot of folks, immunization professionals engaged with, particularly at the subnational levels. And we began to appreciate from engaging with our Boost members that one of the groups that was having the greatest challenges were supervisors at a subnational level who were having significant, challenges managing staff remotely, since it was hard to oversee what they couldn't actually see, and hard to provide answers to questions that there were no certain responses for. It was not black and white. And so, for example, heard a lot about how to manage an overall increase in vaccine hesitancy in a community because of contradicting media coverage about the forthcoming COVID-19 vaccine. And when asking us questions, we don't always have a final specific answer, right? So it made things even more complicated. In the late spring, we launched our first adaptive leadership course, which really focuses on enabling staff to feel connected and empowered and to really drive change. And the challenges that arose during this course, we had about 300 immunization professionals, most at a subnational level, engaged. Was that, again, people were grappling with questions that didn't have one, let alone 10 right answers. And so we were trying to support immunization staff to also work with one another to say, what are your challenges? What are you hearing about? What are the vaccine hesitancy pieces that are coming in your communities? How can we work together to understand how we can grapple with this? So fast forward a couple of months, and in early summer, we began to understand kind of an underlying challenge that immunization staff were also having, was anticipating that there was going to be difficulty in rolling out the COVID-19 vaccine at a national level. And so given many low and middle income countries, of course, do not have life course vaccination programs, they don't have the mechanisms in place to really reach adult populations. And in addition, some of the most in need will be the hardest to reach. And so we're working with JSI and Dahlberg and launched the COVID-19 Vaccine Equity Project, or CVEP, in October of last year. And we worked with the Boost community to understand kind of what are the core equity components that come out, where do we feel like the greatest gaps are and the technical assistance is needed. And what we heard from this specifically around vaccine confidence is that the challenges are really layered, that it can be considered a political misstep to discuss hesitancy or confront it in government, that it needs to be hyper localized, as rumors can be layered and morphed very easily and very quickly, and that immunization staff themselves often do not know how to counter the potential misinformation. For example, again, on the efficacy of a specific COVID-19 vaccine. The 5 core areas that came out of, challenge areas that came out were, of course, community engagement, mobilization, demand generation, as well as effective and inclusive planning, transparent data-driven approaches, equitable and data-driven immunization supply and cold chain, and then healthcare worker and community health worker engagement and training. And of course, you could layer into all this vaccine hesitancy and demand. So CVAP is currently working in 4 pilot countries, offering technical support in those 5 core focal areas. One of the greatest demands from those 4 countries thus far has been around vaccine hesitancy and demand, the challenges that they're grappling with. We'll also soon begin to develop a community of practice where folks can kind of share out learnings and global goods from our work and the work of others, ideally. So we know it's really essential to share out those successes in real time so that folks can learn from one another and we can start a real conversation. Thank you.
Yeah, and that sounds like a lot of work and some very important findings coming down the pike pretty soon. Okay, Lavanya, you're next. Your research has focused on understanding how vaccine hesitancy plays out at an individual level. There has been an unprecedented level of public scrutiny on this vaccine, while at the same time, the variants create a sense of emergency. Tom and Jen have talked about some of the factors that influence people's vaccine decisions. Tell us what you've learned from your research about how people are making COVID-19 vaccine decisions. What are some of the key hurdles in increasing people's willingness to be vaccinated?
Thanks so much for the question, Mike. And as we've been talking so far, the drivers of vaccine hesitancy are known to be multifaceted. And this complex landscape of COVID-19 vaccines just makes addressing vaccine hesitancy even more challenging. We have a lot of evidence on which strategies work. So there are some very well-known strategies for mitigating vaccine hesitancy. So these are things like delivering tailored information that addresses individuals' specific concerns as opposed to untailored information. We know that using trusted messengers to deliver the message appears more credible as opposed to using untrusted messengers. And we know that we have to use diverse dissemination strategies to increase the reach of information. However, in our experience, we find that many of these strategies, while effective and necessary, in sort of this multi-component intervention to address vaccine hesitancy, are insufficient. And I say that because there are several underlying factors that contribute to vaccine hesitancy, which are often overlooked. Now, let's consider vaccine decision-making. So behind every vaccination decision, there is an inherent risk-benefit trade-off that is being made. So for somebody to accept COVID-19 vaccinations, the benefits of vaccinations must outweigh the risks of getting COVID-19. However, we know that the risk of COVID-19 can vary very widely based on age, race, ethnicity, presence or absence of comorbidities, and so on. So as a result, every individual at this point has a different perception of their own risk of COVID-19. And that makes it challenging when you're thinking about risk-benefit trade-offs. On the other side of this coin, when we think about vaccine benefits, we heard Tom talk about the newness of the vaccines, the speed of vaccine development, and this has definitely caused many people to doubt the safety of the vaccines. And although we are building a track record of the safety of these vaccines, lack of concrete statistics on safety of the vaccines in specific subpopulations, so for example, groups with comorbidities, have not only affected the consistency of public health messaging, but what I found more frightening is the strength of recommendations that public health agencies are making in favor of vaccines. So for this reason, many people are using what I would call the wait and watch approach. As new information becomes available and people see data on vaccine safety and efficacy, as Tom mentioned, we are not seeing adverse reactions at the rate that people were afraid. Many of these people who are waiting and watching will eventually get the vaccine, and that's being reflected in the surveys that we are seeing. But if you think about the conversion rate, I think the rate at which people are accepting vaccines is pretty slow at the moment, and alarming when you think about the spread of the variants. So I think we need further research, and specifically research that identifies knowledge gaps among people who are waiting and watching. And we need to identify specific intervention content that can give people the information that they need to make that risk-benefit trade-off. Second, I want to talk about the information that we have right now. And in many ways, we are inundated with COVID-19 information, even though there are knowledge gaps. But the thing to note is that information quantity is not the same as information quality. So vaccine information that we find on the internet can vary from, you have peer-reviewed publications expert consensus statements. But on the other hand, you can have user-generated content, which is uploaded by a non-scientist from their living room couch, right? And then on top of that, you have bots and trolls and other anti-vaccine entities that are deliberately spreading falsehoods. So while this by itself may not be a huge problem, it becomes one when you couple that with hyper-personalization of content by recommendation algorithms on the internet. So this means that many people are trapped in echo chambers of misinformation. And within these echo chambers, negative attitudes are being reinforced, new spurious myths and conspiracies are easily spread, and people often develop extreme views on topics due to the partisan nature of information that's being delivered. And breaking people out of these echo chambers is a hard problem and something that actually requires a multidisciplinary collaboration. And this is also something that cannot be done without commitment from social media companies and the internet giants out of Silicon Valley. And finally, the one thing I will add is, from the research that we are doing, we are speaking with a number of vaccine hesitant individuals. We often find that they lack a basic understanding of science. So for example, they may not understand how the immune system works, what a normal versus adverse reaction looks like. So everything seems like an adverse reaction. And they may not know necessarily how vaccines are developed and tested and approved. So in the absence of this grounding in science, it becomes more easy for these individuals to succumb to misinformation. And I think this issue is exacerbated as anti-vaccine entities are using more sophisticated strategies to distort facts. So I think if we are to address vaccine hesitancy in the long run, we also have to think about bolstering science education in schools. Jen talked about training and building capacity among health workers, but we also need to think about how do we bolster science education among the public. And in light of how our information consumption is changing these days, this education should include training on distinguishing misinformation from scientific facts. I think there's a lot for us to do beyond the obvious strategies of addressing vaccine hesitancy, and there are some systemic changes that are needed if we are serious about addressing vaccine hesitancy.
Thanks, Lavanya. I think you nicely point out that this has got to be a societal response. There's not a single bullet here magic bullet that's going to turn this around. And your comment about the variants, on the one hand, sometimes people say, well, there are variants, why bother to get vaccinated? On the other hand, we need people to get vaccinated so we have less variants. And so the challenges are great. I'd like to, before I turn to Mohammed, we're starting to get some questions. Please, audience, send in your questions to our panelists on any related topic, and I will try to get to them before we run out of time. I'll try to summarize them, and let me ask for now that Mohammed, you be our next speaker. And Mohammed, you were the individual that brilliantly led a polio vaccination campaign in Nigeria, which really eradicated the disease. And I've heard you talk about the case study and how you did it. At one point, Nigeria accounted for half the cases in the world of polio, with high resistance to the vaccine in many parts of the country. Can you share with us what factors, political or otherwise, allowed you to overcome these and have a successful campaign? And what lessons can we learn from that polio work that we can apply to COVID today? Thank you, Mike. I think many of the lessons have been sort of touched upon by the preceding speakers, Tom, Jen, and Lavanya. Let me say that the issue of vaccine hesitancy, there's sort of the individual dimension to it, but there's also sort of mass rejection. In the case of polio eradication, block rejection and mass rejection was quite prevalent. And the diversity of the reasons for that mass rejection, I think, it's been touched upon already. Part of it is lack of information or misinformation.
which is very prevalent in the case of Nigeria, conspiracy theories around fertility reductions in the northern parts of the country. Those fueled some of those mass rejections that we saw. Some of the reasons included historical reasons. In the case of Nigeria, we had Pfizer, trovafloxacin trials in the mid-90s, which unfortunately had some missteps that became etched in people's mindset in terms of introduction of new technologies that affected the trust level in terms of what people accept to be good information to act upon. And thirdly, there may be sort of the political angle to it. And that was an important part driving mass rejection for the polio eradication in Nigeria. And what I'm saying here is misalignment of global priorities with local priorities. An example for me was when I went to a rural area and asked, why are you refusing in the entire village? And the answer was, well, we had children dying of measles and there were no measles vaccines. And yet we have repeated doses of polio vaccines brought to our own houses. Why? So the misalignment between sort of global priorities and the global health security dimension and community felt needs itself can fuel sort of the skepticism and suspicion at large scale. So in a way, aligning within the context of what people's felt needs are, framing any vaccination effort within that was very necessary for us to be able to deal with the polio eradication. Another aspect of the political angle is the legitimacy of the channels. I think Lavanya and also Jen also referred to it. The external legitimacy that we think institutions have may not necessarily be the same that the people themselves look to them too, where governments have failed in providing basic services or there's corruption or whatever it is, fuels the lack of trust in terms of the messages coming out of them. You see that in poor countries, and you see that also even in wealthier countries, what you see in the politicization of the rejection of science, for instance, that is linked to political ideologies, that link to the legitimacy of the state itself, that channels itself through the trust or lack thereof in terms of what comes out of it. And then the organized campaigns, because you'll be surprised in northern Nigeria, folks were bringing to me truckloads of information from USAID population project in the 70s and saying, well, this is being fueled by global anti-vaccine movement. Now, all of those really compounded the situation and led to widespread mass rejection, or what we call block rejection, which in a way sort of adds to the issue beyond sort of the individual decisions, which is inevitable and is present everywhere in the world. So in the case of COVID-19 pandemic, drawing from those lessons, I think how we frame the COVID-19 vaccination effort will be very important. If we frame it in the context of also strengthening health systems in an integrated manner that looks at the overall welfare on sort of the needs of communities, starting with addressing the COVID-19 pandemic, I think it will have a much better chance of minimizing mass rejection than if we sort of parachute the vaccines in a situation where people are actually lacking the most basic needs. That's one aspect. Not to say that it's the same population as, let's say, polio and other routine vaccines, but I think the relative emphasis that we place on COVID-19 relative to the other needs, I think is important. And so for the World Bank, for instance, the $12 billion that we put on the table for vaccine financing is framed within the context of the vaccines for COVID-19, but also strengthening primary healthcare systems. Secondly, transparency is vital. I think Jen mentioned it, because without transparency, both at the global level as well as at the country level, the reason for trust or trust will not be earned, because we ask people to trust us to deliver, to accept the vaccines, but not asking, are we trustworthy enough for them to be able to take what we say? And to earn that trust, transparency is key. In northern Nigeria, engagement with traditional and religious leaders and putting all our cards on the table, including on vaccine-derived polio virus, helped us to earn that trust with the communities for them to go out from being the obstacle to being really the pathway to the solution to mass rejection that allowed us to really be able to eradicate polio. And intentional community and citizen engagement is also important, not just to go and tell people, okay, just take this, it's good for you, but really engaging with them, like Jen mentioned, in the planning, in the implementation, in the oversight, and the feedback loop. So they actually own it, not just light touch. We've sort of given you the information, just go do it. That isn't going to work. And then proactively countering the messages that are out there. I think we need to do a lot more in that. And I think Jen also referred to some of the efforts of WHO, UNICEF, through the COVAX, and also through our own financing in terms of the World Bank financing. But broadly, over the long term, because it's not just about COVID, the idea of vaccination is so important for infectious diseases beyond COVID, and to really think about that in a way that also responds to the needs of communities. Governments all over the world will need to sort of listen to the needs of their populations. That's the best way to earn the trust. If you look at the vaccine hesitancy, it differs in different countries, but I think there's an element of really the engagement, the legitimacy, and also the community felt needs and the framing that is also important. Those are some of the lessons that I think we can learn from the polio effort, and also try to apply it in the context of COVID-19 vaccines. So I'll stop here. Happy to take any questions.
Well, Mohammed, your point, I think it relates to the Ebola vaccine experience also, I believe, of thinking of the vaccine not as an isolated delivery strategy, but integrated first into the immunizations in general, and then secondly into the broader healthcare needs. It seems to be, I take that as was a profound factor in Nigeria with polio.
Yeah.
Okay, we have quite, excuse me, about a lot of questions. Let me ask Lavanya, I want to come right away to one that I'm getting the most questions about. And that's what you briefly mentioned. But I want to know if you have any other thoughts about how to cope with the enormous amount of social media that really is out there. And we've had social media now for many years, but it's reached new levels, and is a greater challenge than it's ever been. Do you have any thoughts on how we counter? Any more thoughts on how we counter what people are hearing in particularly low and middle income countries? Is there any hope of getting more cooperation? I'd be interested if you have any thoughts on that.
Yeah, Mike, that's a really interesting question and an important one. And I've spent some time thinking about, why is it that people go to social media in the first place? And the only answer I can think of is because in a lot of circumstances, people don't have access to healthcare or healthcare personnel who can serve as trusted sources of information. So if you consider rural America, for example, or rural parts of any country, people have limited access to healthcare, which means they don't have a health provider who can make vaccine recommendations. They don't have somebody to discuss their concerns with. In the US, there's a lot of gatekeeping around vaccination or appointment times, reimbursement for providers. And so the capitalist approach here in some ways contributes to people looking for information elsewhere. And where do you go if you want to look for information elsewhere? You go to the device that's in your pocket, which is your smartphone, right? Which is connected to the internet, which has all the information, answers to potentially all the questions you're looking for. But the problem that we face there, as I mentioned earlier, is just the diversity of information and the lack of information quality. So I think the basic problem that we're experiencing right now is anybody can post anything to the internet, to a blog, to social media, and there's no way for us to say, that you cannot post something. And there is also, I think, no way to provide enough resources to moderate the content that's being posted. I know social media companies are making an effort by, you may have seen the notifications that appear, which say, this information may potentially be misinformation, or, for accurate information about vaccines, go to cdc.gov or WHO. But those kinds of notifications only help to a certain extent. I think after a certain point, people start to glaze over those notifications. And there's a missed opportunity with those notifications of educating people in terms of why the content is misinformation. And I think that's where one of the biggest gaps is. And so what we are doing at Duke is I'm working with people in the Department of Computer Science to not only figure out more intelligent ways to tag misinformation, but also think about how we can leverage artificial intelligence, machine learning, and natural language processing as ways to not just tag something as misinformation, but also identify content that can be used to, or content that can be presented as counter arguments. So I think there's a gap right now in those technologies, in those techniques. We don't have those interdisciplinary frameworks and taxonomies. So I think we need more investment in research on those topics. But even there's always this question of how much can we scale? There's, the amount of user-generated content on the internet is immense. And so there's always going to be this problem, but with enough investments in research and better commitments from internet giants and social media companies, I think we can get closer to addressing the problem. And then I always go back to what I mentioned in my previous response, which is we need to start educating people about identifying misinformation. Many people don't know that WHO actually has on their webpage information on what they consider credible websites on vaccines. And they have a vaccine safety link endorsement that they make for websites that that meet all the credibility criteria. So I think it's important to educate people about, how do you identify whether a source of information is credible or not? How do you spot signals of misinformation? So I think we need to start focusing on educating people about that.
Lavanya, what I take away is we need to be much more proactive in dealing with this and not just sit back and flag messages or just say it's not a good thing. There has to be a proactive strategy and we don't have good ones right now. And I think that's an important point. Let me ask you a question that has been in the news quite a bit in the last few days. A new term called vaccine alarmism. And what this is referring to is experts like all of you on this panel underselling the great benefit of the COVID vaccine. Unfortunately, media at times likes to pick this up, whether it's about the variants or the vaccine's not working in certain places as well as they do in others. Don't we need to do more maybe about reminding people how much these vaccines do work? Isn't there don't experts maybe need to rethink a little bit about how they convey the message to the media about these vaccines?
Short answer is absolutely, Mike. Yes, we need to do that. I think one of the problems we have today is that in this media world that we live in, and we as scientists communicate with each other in a critical manner. And that's how science progresses and develops. That critical communications between each other on science and science facts can be a soundbite that translates into something that creates a lot of uncertainty in people that just do not know the science as well. So I think we as scientists or people that work in this area have to be very careful when we're critiquing a trial or a development of something, that we're not saying the whole thing is horrible. We're saying, we're raising some concerns or some questions, but at the same time, we should be illustrating all the success. And that's why, I started out with, and every time I'm asked questions about COVID vaccines, I try to come back to, it's an amazing amount of science that we've done in 1 year, from identifying a new pathogen. Look, Mike, you and I have been around doing HIV work for many years. We're 30 years plus into this, and we do not have a vaccine that's protective yet. We get close, but we don't have a protective vaccine. So I think we've come an amazing distance, and we need to point out all of those amazing successes that we have. And yes, start convincing and helping the public to understand that we do have safe, that these vaccines are safe, and stop raising the alarm or the concerns that we have that may end up doing the opposite of what we're trying to do here with providing coverage. I think the other thing we need that we have to find a way to do is we need what I call vaccine ambassadors. You and I, and those of us here, it's hard for us to communicate sometimes or convince the public that they should do something. But if we have peers, and what I say to, in the sports field, in the entertainment field, if we have people in those fields that people look up to, more so than scientists, that they then become vaccine ambassadors and help to convince members of society that this is a good thing to take the vaccine and not to be concerned about it. So I think we need to do more work in communicating the safe parts of it. And then we also need to communicate more about, what scared me over the last year was the risk of being infected and being in an ICU unit. So for me personally, the risk benefit part of, taking the vaccine versus becoming sick and being, very sick in an intensive care unit, the vaccine was an easy decision. And if you look across the spectrum of people that have been infected with, it's not just the older and those that have, compromise, a number of underlying medical issues. There are young people that die every day or every week around the world from being infected that are healthy. So we don't have the tools of the science to predict who's going to do well and who's going to do bad. So in that underlying, issue, I think we really need to start talking about, dampen down the alarmists, show the success that we've accomplished, and hopefully get the vaccine uptake numbers up a lot higher, a lot faster.
Well said, Tom. Mohammed, we've got a whole bunch of questions about what's happening globally. Let me try to put them all together. As you know well, we've got some real issues around disparity. At best, we're hoping that let's just say the countries in Africa can get 20% of their population vaccinated. This is at best in the next year. And this obviously puts great pressures on countries running around to using the COVAX facility or not to try to get vaccine from somewhere. Often it's going to be an Indian or a Chinese or a Russian vaccine. Then we have some countries, and one country we know about here is Peru, where there's even been some local scandals about vaccine and what vaccine they should get, if any. How is the world preparing itself to deal with the challenge of vaccinating? We've never had to do this before, vaccinate 8 billion people. The bank seems to me, you mentioned the contributions you're giving, but where's the leadership going to come to deal with these, probably one of the greatest global challenges we've had in history?
I think that's a very good question, Mike. I think the fact that we have vaccines being deployed and more than half the vaccines that have been deployed so far are only in 10 countries is scandalous. The fact that 130 countries have yet to immunize a single person is scandalous. But that doesn't take away from the tremendous progress that we have seen within a year of the pandemic. And I think Tom mentioned it in terms of the positive development in terms of having a vaccine within a year compared to what we had in the past. But I think we should always strive to address those massive global inequalities. How have we tried to deal with it? February, just around this time last year, was when the global community, the bank, CEPI, Gavi, and I think Gavin Yame from the Duke Global Health Institute with us, kicked off the Vaccine Development and Financing Task Force to start considering at the global level how to accelerate the phase 3 trials, but also the manufacturing at risk for globally fair allocation and access in terms of the global community to avert what could have been a lot worse situation. That work fed into the ACT accelerator and the development of COVAX by Gavi, CEPI, and WHO. of which the bank is part of that loose alliance of institutions that included the private sector. That mechanism has provided, let's say, a platform for mobilizing the resources, engaging the partnerships at global level, raising the resources through the COVAX AMC for the 92 lowest income countries, and also other self-financing countries, that in the next couple of weeks, we would expect to see more vaccines, the AstraZeneca vaccines and other vaccines, Pfizer vaccines in some countries being deployed. That will be, let's say, later when you look at it in relative terms, but unprecedented when you look at it in context of history of our dealing with pandemic. So organizing multilateral institutions or the private sector institutions in sort of a network governance model, I think is the way forward, because no single institution by itself will be able to address this. So learning the lesson from COVID-19 will be very vital for us as we think of other things that are coming down the pike in terms of R&D, how we finance it, and how we finance manufacturing at risk. Did we get it all right? I think there's still a lot of difficulties, but I think we've done, as a global community, we look at the ACT accelerator and the COVAX mechanism really tremendously well. It could be better, and I think we should push for it to get better so that the time between when vaccines are available in the highest income countries and when it is available to the lowest income countries will be shortened. That will be in everyone's interest to be able to do that. And the World Bank is very much part of that conversation, along with WHO, UNICEF, Gavi, CEPI, and many others.
So patience, some patience. I hear, Mohammed, we can't get there tomorrow, but you feel things are going in the right direction.
I think they've gone better than, let's say, it has ever been in terms of vaccine development. But we have to be impatient in terms of the inequalities that is being sort of manifested through this. I don't think we can tolerate that. The fact that 130 countries yet have no vaccines, I think it's sort of a dualism. On the one hand, something very positive has happened, and we cannot take that away from the global sort of community coming together. But it could have been a lot better had there been a firm global consensus, let's say by summer of last year. And partly it's not really a technical issue, it's really a reflection of the political landscape at the global level and the leadership that was needed to pull through a single globally coordinated multilateral mechanism. But we've come far despite that political difficulties that existed in 2020. So things will be better, I hope.
Very well said, Mohammed. Very well said. Okay, we don't have a lot more time, but Jen, I want to ask you, there is interest in health systems. Mohammed mentioned to this. How can we help and strengthen health systems to support better management of vaccine hesitancy? You have some data, I think, you're working on, but what have you learned so far about how to integrate in an efficient way COVID vaccine delivery with the overall strengthening of the health system around vaccines and other health interventions? You want to comment on that?
Sure. And sorry, I dropped off. Of course, my internet dropped in the middle of this.
Okay.
I think that the investments that we're making, and I think Mohammed, you talked about this, we have to be thinking about the long-term health, the sustainability of the system. And what we're seeing, and I think appreciating, is that the investments that we need to make in the system are the investments in the people. And it's in the people at, yes, the national level, but as I mentioned earlier, it's at the subnational level. It's, take one county in Kenya, and the lead for vaccines there will be managing, 8 to 10 million, a population of 8 to 10 million people. And so we really feel like the investment that needs to happen is in the kind of leadership capacity, management capacity, community building, and also finding a space for folks to connect with one another and a space for folks to be vulnerable and talk about their challenges in their everyday, appreciating that there isn't really that time and space and, within their colleagues, their immediate colleagues. And so figuring out what that can look like, I think is really important.
Okay, good. That's a very good way to start to wrap this up. We have about 4 minutes. I'm gonna do something that's a little risky. I'm going to ask each of our panelists if they would just, don't think too long, if there was one thing we could do to alleviate vaccine hesitancy right now, if money wasn't an issue, resources weren't an issue, I'm trying to think together, what's our greatest barrier and what do we want to do about it? If you have to pick, if you forced yourself to pick something that you think is the one thing we really need to overcome, would anyone want to tell us what that would be? Any of you four?
For me, it's safety. The more we can do to convince people and to show people that vaccines are safe. You know, we over the years, there's always, coming up with something negative on vaccines is very easy. And you can get a soundbite there. Convincing people to safety takes a lot. And I would say anything we can do to figure out ways to communicate the safety of this particular vaccine, but as we've talked about, the importance of vaccines in public health and global health, through history and going forward, I think that's one of the biggest obstacles to vaccine acceptancy, I think, is to
so focusing, Tom, that there's no harm, I guess, right?
No harm, and being able to show being able to show in more real time the amount of vaccines that are being administered. And I haven't heard, at least on the nightly news, I hear what the death rate is, but I haven't heard that 65 million people have received the vaccine. And, there's been there has not been 1,000 of them admitted to the ICU unit as an adverse event. So communicating the positive parts of it, as opposed to the negative aspects of the disease and the consequences, I think doing a better job there, I think would help to convince the public across the globe that vaccines are safe.
Very good. Any one of our other panelists want to add to that?
I will add, Mike, I think there's nothing that earns trust more than full transparency. So transparency at the global level and within countries, who gets what, where, the good, the not so good, will serve us very well in terms of stewarding the vaccine deployment across countries. The fact that many contracts, the bilaterals, there's not much information around it. The lack of transparency, in a way, fuels this sense that maybe there are sort of 2 or 3 tracks, or certain vaccines for certain populations and certain for others as well. Yeah. Just coming clean will be the way to earn trust.
And that takes also what you mentioned earlier, global leadership and global solidarity. That's, I guess, part of that, right, Mohammed? That's critical to have that happen.
Yes, transparency is, I think, a key attribute of global leadership that we should aspire to as a collective.
Right. Okay, Jen or Lavanya, I haven't heard your thought.
Yeah, I mean, I think I'm a broken record at this point, but I would focus on supporting the local staff on that leadership point, really enabling folks at that level to have the capacity and support they need. I also think investing in a way and a mechanism to have local folks have a seat at the big tables, so we really understand what's going on and how we need, how we need to support these folks. So,
okay.
And I will just add to what everybody said, and say that I think addressing misinformation is a big need. At this point, misinformation is drowning out science, and we know that misinformation kills. The positive that I take away from all of this is, people are interested in information. People are looking for information. It's just, whether or not we are able to get them the right information that can save lives. So I would focus more on developing more intelligent, sophisticated, and automated tools with all the techniques and technologies that we have, to make sure that the benefits of vaccinations are communicated in the right way.
Okay, well, great. Thank all of you. It seems to me we've got a nice conclusion of where we need to go. We need to stress our messages on safety. We need to fight misinformation. We need to be as transparent as we can. with global solidarity, and we need to not forget the importance of focusing on local populations. So that's our agenda for vaccine hesitancy, and some nice conclusions, I think, for our webinar. I want to again thank everyone for participating. I want to ask that you all remember that we have a third webinar in our series coming up on March 16th. There'll be messages coming out from 8 to 9 a.m. We will discuss COVID-19 vaccine manufacturing, intellectual property, logistics, and supply chains. So with that, I thank you all and wish you a good day.